شكرا لشركتي وفارما على دعمها نشاطات الاسم. ونبدا بسم الله الرحمن الرحيم. Fractures of the spine in children. The important differences between
يا دكتور محمد اعمل شير سكرين الاول.
انا عامل المفروض شير سكرين ولا مش طالع؟
لا مش طالع عندي حاجه. اتاكد ان السكرين شيرد.
طيب انا كده تمام. يعني كده شير ده يا دكتور خالد ولا انا مش
لا
مظبوط؟
لا لسه انت عندك الامكانيه انك انت تعمل سكرين شيرنج يا دكتور محمد. اعمل شير سكرين من عندك وانت فاتح البرزنتيشن، هتلاقي البرزنتيشن ظهر عندنا كلنا على طول.
شير سكرين تمام. كده مظبوط. حضرتك شايف الشاشه اللي قدامي دلوقتي؟
بتستنى شويه كده وبعدين بتبان.
مظبوط.
مفيش اي حاجه ظهرت عندنا لسه يا دكتور محمد.
انا طالع لي كده ان انا شيرد دلوقتي، العلامه اهي.
طيب لحظه.
تمام كده دكتور.
كده مظبوط تمام.
تمام يا فندم.
بسم الله الرحمن الرحيم.
اتفضل يا دكتور محمد. اتفضل.
تمام. Important differences between pediatric spine and adult spine is not only the size. It's not only about little adults, but there are anatomic and radiographic differences and variants. The pediatric spine is more flexible, large head ratio in relative to the body. We will see this in the mechanism of injury later on. So surgery usually is rarely indicated than adults, and immobilization is always well tolerated than adults. The incidence, زي ما حضرتك قلت يا دكتور خالد, it's very rare injuries, 108 per million. Usually male a little bit more than female, and higher risk more than 15 years, usually motor car accidents, falls and sports, and rarely non-accident trauma. Injuries are more of cervical spine injuries, less than 4 years. After 5 years, mainly lumbar spine, a little bit more than common than the cervical spine. Cervical spine injuries are rare, less than 1% of children fractures, rare to cause neurologic injuries, up to 44%, and rare to cause mortality, especially before 9 years old. Before the age of 7, the majority of injuries are upper cervical. More than 7 are usually subaxial spine. Upper cervical anatomy have little bit differences, which will cause the more injuries of upper cervical spine in young ages. The occiput C1 articulation is horizontally based, and as we said, the child large head in the relation to the body. That's why occiput C1 injuries is more common in younger ages. Anatomy of C1, at birth there are 3 ossification centers. The body and the 2 arches are separate, and at 7 years C2 have 4 ossification centers, which fuse from 3 to 6 years old to neurocentral synchondrosis and dentocentral synchondrosis. That's why no physis should be visible on the open mouth odontoid X-rays after the age of 6 years. This is important for differentiation fractures from the normal variations. There is summit ossification center appears from 3 to 6 years and fuse at 12 years old. which also can misdiagnose with the os odontoinum. Subaxial cervical anatomy, the body and the neural arches are separate. The vertebral bodies are wedged until the age of 7 years, not to confuse with compression fractures. Superior and inferior cartilage in the plates firmly attached to the discs. That's why usually it's very rare or never to see disc or traumatic disc diseases, traumatic disc injuries in pediatrics. The mechanism of injury usually is the junction between the cartilage end plate and the bony vertebral body. The fractures split the end plate between the columnar gross cartilage and the calcified cartilage, and does not typically occur by fracture through the end plate disc junction. The transportation, there is also due to the large head size, usually the board cannot be used because it causes flexion to the adult head. So there is pediatric boards for transport with the opening for the head, or we can elevate the body to accommodate for the large head size. As we see here, we used a normal board for the transportation, and it causes this flexion, which may worsen the injury if there is a fracture. C-spine evaluation in children. The mechanism of injury should be known well. High incidence associated, of course, of systemic injury should be ruled out. Physical examination, we should examine for tenderness and the neurological tenderness in the midline, and for neurological examination, mainly reflexes. X-rays are not commonly used, and CT scans are preferable, and there is low threshold to obtain MRI, as we will see, because of the sciura and the spinal cord injuries without visible X-ray and CT changes. C-spine X-ray evaluation, as we said, the normal ossification centers should be known. C2-3 pseudo subluxation is common in children before 8 years, so we should check the spinolaminar line of Schwischak, and this is the spinolaminar line between C1, C2, C3. This is mainly in children, should be inspected well. Evaluation of anterior soft tissue is unreliable in crying child, which we usually see in adults. In uninjured normal patient less than 8 years, 20% can demonstrate ADI between 3 to 5 millimeters, which is considered more than normal in adults, but this is normal due to the flexibility or augmented flexibility in children. As we see here in these photos, this is the spinolaminar line C1, C2, C3. We should be aware of these normal radiographic findings. The ossiculum terminal, C1 override C2, as we said, the C2, C3 pseudo subluxation, the ADI distance, any normal synchondrosis, odontoid angulation, vertebral body angulation, اللي هو wedging. All these are normal variations. If you are not aware with the normal radiographs for the children, can be misdiagnosed. The pediatric cervical trauma patterns. Number one, the atlanto-occipital dissociation, usually high energy trauma, usually fatal injuries in patients with atlanto-occipital dissociation. Occipital fusion is required as a treatment, as halo immobilization is insufficient for these injuries because the ligaments are very flexible. Odontoid fractures are the most common pediatric cervical spine, especially before 7 years old. The mechanism of injury is hyperflexion. The fracture is through the dentocentral synchondrosis. The presentation is usually significant apprehension and torticollis. Lateral radiographs demonstrate the anterior flexed position of the dents. CT scan usually get the diagnosis. Neurological function usually is intact because the canal is very wide in front of C2. The treatment involves usually reduction and demobilization in halo for 6 weeks, or reduction under anesthesia, and very rarely in children who are involved in high energy sports. C1, C2 rotatory subluxation or traumatic torticollis can result of major trauma or minor trauma after kinds of infection that weaken the transverse ligaments, present with neck pain and spasm and hold the head rotated to one side, اللي هو called the Cook-Robin position. Confirmatory CT usually sufficient for diagnosis. There is the Fielding-Hawkins classification of the severity of displacement, as we see the 4 grades of this injury, and high speed mechanism with torticollis deserve further workup and MRI, because to exclude the spinal cord injuries, the low speed, that's why the mechanism of injury is also important, and those low speed trauma after upper respiratory or pharyngeal infections, usually the treatment of the cause and immobilization for 4 to 6 weeks is sufficient after proper traction and reduction under anesthesia. The subaxial injuries are more common in adolescents and older children, usually motor car accidents or sports. Injuries include spinous process, mainly avulsion fractures and ligamentous injury, sometimes facet fractures, compression fractures, of course, and burst fracture. Treatment revolves around the injury pattern. The stability in this pattern usually can be classified like the adult injuries, type A and type B as the AO classification, for example, according to the stability, and we treat accordingly, because most of these injuries are adolescents, which the plan of management usually is quite similar to the adult plan of treatment. Traumatic spinal cord injury in children is rare, and they have better prognosis for recovery than adults. They should be treated aggressively with immobilization and decompression than adults, because they can improve well, and paralytic scoliosis can occur, and all the quadriplegic children will experience this kind of scoliosis due to the loss of truncal support muscles. The sciura, this is the spinal cord injury without radiographic abnormality. This term was, this radiographic abnormality means that in the X-ray and CT, the regular radiographs that are taken in the ER, this happened due to a distraction mechanism. The spinal column is more flexible than the spinal cord, so this is a traction injury, and looks normal in the X-ray and even in the CT. Usually occur in the upper C-spine and below 8 years. MRI can get the diagnosis, and it decreases with age. And if we have Glasgow coma 3 child with normal CT head and patient is in neurogenic shock, this should be highly suspected, and MRI is mandatory in these cases. Here we have the clearance protocol for the C-spine. If it has a child with the C-spine collar, abnormal radiograph transferred to the spine unit. If trauma evaluation, if and AP and lateral views, if they are normal, and the child is older than 3 years and can communicate, we can use the nexus criteria for evaluation of clinical evaluation for the spine. Absence of midline cervical hardness or no evidence of intoxication, normal level of alertness, normal neurological examination, absence of any painful or destructive injury, we can then consider this patient clear. If there is any suspicion, usually we transfer for CT, and in the presence of any neurological abnormalities, even with normal CT, MRI is mandatory for, especially in children. If you see a spine fracture in child, look hard for another one, because the most commonly missed spine fracture, is the second one. There's high incidence of non-contiguous spine fractures in children. Now we move to the thoracic spine fractures. They are less common spinal fractures in children than more mobile regions because the rib cage over support, usually motor car accidents, sometimes the child abuses mechanism of injury. Usually they are compression fractures, especially in those who are highly osteoporotic like osteogenesis imperfecta or children on the chemotherapy. And again, we should, if we notice a thoracic fracture, we should look for another fractures elsewhere. This is an example for thoracic spine spinal cord injury. Prognosis recovery is recovery and occur more and have some role اللي هو الارتري of Adam Quicks, especially in delayed paraplegia. Thoracolumbar junction injuries T11 to L2, they are usually flexion destruction injuries, chance fractures and variants. They are highly associated with intra-abdominal injury up to 90% sometimes. Neurological injury is infrequent but can occur, and if it occur, usually it is a severe one. Lumbar apophyseal injuries or slipped apophysis usually occur due to a compression shear injuries, the same age group as the slipped capitofemoral epiphysis and the same risk factors. Typically, adolescent males, inferior end plates of L4 and L5 is the most common places. Traumatic displacement of vertebral ring apophysis and disc into the spinal canal. If causes significant compression of the coda equina, of course, urgent surgical decompression should be done. And there are three modes of this lumbar of their injuries, as we see in this diagram. Lastly, the chance fractures and variants, they occur in the posterior elements fail in tension, anterior elements fail in compression, usually also in adolescent children and near the age of the adults. And the pure bony injuries can be treated with immobilization in extension. Partial or whole ligamentous injuries are best treated with surgical stabilization. This is the classification of the seat belt or flexion destruction injuries, either trans-osseous or purely trans-ligamentous or mixed type or mixed type with rotational instability. This is the lap belt sign, and if we see this sign, usually it's high possibility of intra-abdominal injury and with the lumbar spine fracture. So in this case, we should be aware of the intra-abdominal visceral injuries and should be ruled out. This is, for example, a 4-year-old lap belt restrained passenger intra-abdominal injury with paraplegia and was also associated with intra-abdominal visceral injury. This is another example of 2-year-old with old L2, L3 fracture dislocation. Lumbar spine fractures in the lower lumbar L3 to L5 is infrequent until late adolescence, and usually compression fractures and stable fractures. Burst fractures may progress to kyphosis usually, and lumbar apophyseal injuries with posterior displacement can cause stenosis and may need surgical excision more than any other area in the spine. Here we have a flexion destruction injury L2-3, 6 months after compression fixation posterolateral fusion. This is the final radiographs. Burst fractures usually occur in older adolescents, and treatment is similar to adults. May not need surgery if neurologically intact and without posterior ligamentous complex injury. Injuries in the thoracolumbar junction is the high risk to progress for kyphosis because it's a junctional area. Thank you.
شكرا دكتور محمد. عرض موجز ويعني غطيت الموضوع بشكل جميل الحقيقه، وطبعا دي بتبقى افتتاحيه بالنسبه للناس اللي انترستد ان هم يعرفوا معلومات قيمه عن
هو الموضوع عريض يا بيه بصراحه وحاولت المه يعني.
وطبعا التفصيل في كل نقطه فيه هيبقى يعني
ممكن يبقى موضوع محاضره لوحده.
بالظبط كده. لو خدنا كل سيجمنت من السيرفايكال سباين هتحتاج محاضره لوحدها. شكرا دكتور محمد على تعبك في معانا وعلى المحاضره الشيقه اللطيفه جدا.
ربنا يبارك فيك.
Now the floor is open for discussion. نرحب بالاسئله من جميع الزملاء الحاضرين معانا من داخل وخارج جمهوريه مصر العربيه. لو في اي اسئله، الاسئله كلها مرحب بها ان شاء الله. طبعا ده ما يمنعش برضو ان ممكن سؤال عن السيرفايكال سباين فراكشرز ان تشيلدرن يجي في الامتحانات. وعلى فكره كتير جدا من الاسئله في الامتحانات هي من وحي هذه السلسله من المحاضرات على فكره، من ايام ما كنا بنعمل محاضرات في القسم.
سؤال مشهور بتاع الروتاتوري سبلكسيشن ده
أيوة بالظبط
كتير.
بالظبط في الاطفال. وبعدين برضو السؤال الشهير ازاي نعرف اذا كان ده تروماتيك ديسلوكيشن ولا بسبب روماتويد ارثرايتس مثلا على سبيل المثال. وبعدين كمان السيرفايكال سباين انجريز على مستوى الاطفال بالتحديد يعني لها سبيشال سيجنيفيكانس علشان البروفاوند سيكولي اللي ممكن تحصل بسببها يعني. واضح كده ان مفيش اسئله، مفيش اي اسئله وصلتني على الشات. نشكركم شكرا جزيلا، والشكر موصول لجميع الساده الزملاء الافاضل الحضور من داخل وخارج جمهوريه مصر العربيه. وشكرا للدكتور محمد عادل على المحاضره الشيقه الممتعه. وشكرا جزيلا لشركه ايفا فارما على تواجدها معنا ودعمها المستمر للنشاط العلمي للقسم. ونشوفكم الثلاث الجاي ان شاء الله، وتصبحوا على خير، والسلام عليكم ورحمه الله وبركاته.
وعليكم السلام.